Hi, everyone. My name's David Pontin. I'm an emergency room physician based in Yellowknife, where I've worked for the last 13 years or so. And I presented at Cabin Fever this last year on a concept that's near and dear to my heart, the concept of clinical courage. And clinical courage plays a very, very big part of practice in the Northwest Territories, both in my setting at Stanton Territorial Hospital, but even more in many of the remote settings that we serve. And the concept of clinical courage is one that's gaining increasing currency in academia, as well as in the teaching world of Canada and the teaching world of rural and remote care. So I'll talk a little bit about that today. So my objectives today are to explore the concept of clinical courage. Like, what do I mean when I talk about clinical courage? And really understand the dimensions of this concept. The second thing I want to talk about is how the College of Family Physicians understands this concept and how we might try to teach it as a teachable competence. And then lastly, I'm going to talk briefly about system supports for physicians who are working at the edge of their competence, and some of the ways that the Northwest Territories is trying to support doctors and their clinical courage. So a little bit more about my context and why I think clinical courage is such an important part of it. The Northwest Territories, I think we all know the map of Canada, but it's big, right? It's the size of Western Europe. There are 33 communities in the Northwest Territories that's spread over this massive geographic area. Very few of any of these communities are connected by ground, so they almost all rely on air transport. Our catchment area at Stanton Hospital also includes the western part of Nunavut. This is an area called the Kitikmeot, and so this adds another big geographic chunk to the area that we serve. And it's basically really, really small communities. Like, once you get out of Yellowknife, a town of 20,000 people, you start getting into really remote places. Some of them only 5 or 6 people, others maybe 200, some of them as big as 2,000. And they're served by a combination of smaller hospitals, Nuvik, for example, and then they get progressively smaller health centers that are staffed by community health nurses or CHINs, and then in some cases they're literally just health cabins, and these health cabins are staffed by local lay dispensers. What you'll see here is a map of the Northwest Territories to give you a sense of how these communities are spread out across the Northwest Territories. That black line you see when you look to the left-hand side of your screen that kind of wiggles its way from the south part of the territory to the north isn't a road. That's the river, and many of our communities are spread out along that river. This is a picture of a health cabin, and in fact, this is a picture of a health cabin where we had a plane crash this last summer, so in the summer of 2018. And so you can imagine, right? I mean, if you were a lay dispenser or a nurse working in literally a cabin, looking after critically injured or critically ill patients, you need a lot of guts to do that, and you need supports to be able to manage these kinds of really sick people. So when I started to explore the concept of clinical courage, it's clear that in rural Canada, and in the north in particular, you require courage to do that kind of work. It really requires, at times, working at the edge of one's scope and negotiating through this very complex world of fear and risk. Unfortunately, there's really not much in the literature about how we navigate this issue. And so my approach to this problem when I started thinking about clinical courage was actually to go to frontline practitioners and ask them really 3 questions. What is clinical courage? Number 1. Number 2, how can we teach clinical courage? And then again, how does the system support clinical courage? So those were the 3 things that I approached them, and I did a number of interviews, and 3 of which that I think I will share with you now. So one of them one of the interviews was really interesting. It was a family doctor early in her career who has a practice, family medicine practice in Fredericton, New Brunswick. Her practice is mostly office-based and does some hospitalist work there. But she also comes up once, twice, 3 times a year to work in the Sawtooth, so one of those regions I showed you on the map earlier. So this is one of the remotest areas in the country with very small communities that have lots of trauma, lots of sick people. And so I asked her, like, how do you make this transition from essentially a city-based urban practice to these really remote places? And what in your mind is clinical courage? And so she described herself as not a thrill seeker, and she feels that clinical courage comes from fear that must be confronted and overcome. And for her, that links to the fact that she's a marathon runner, and she really has always felt to her life that challenge or pain is actually really, really good for growth. And so for her, working in small communities is a really important way for her to grow as a physician. Clinical courage for her involved understanding your limits and being really honest about them, and then really preparing yourself for worst case scenarios. And so when she flies across the country from Fredericton to the Sawtooth, she runs through a whole bunch of scenarios in her head and writes down all of the different ways and how she's going to be manage those various things. So she mentally prepares beforehand. But preparation wasn't only for her working through scenarios. It was also establishing a group of supportive team members and building relationships. So the first thing that she did was actually do a locum in Yellowknife. And that created a bunch of relationships with the consultants that she knew that she was going to have to work with. She came to our emergency department, introduced herself there, got a sense of how the system works, and then felt comfortable enough that she could work in our system and have the backup that she needed. The other thing was more of an informal kind of support team. So she knew, she has a bunch of friends and colleagues in Fredericton that she had on her iPhone Rolodex that she felt that she could call if she ever got into a situation where she needed help. And so she often drew on those kinds of more informal types of networks as well. And then preparation is also psychological. So, for her, she really felt that it's sort of a philosophical sense of knowing that you can't do everything, and that what might actually be what someone in Fredericton might expect for care, or they may not get really sick or even die from something that may happen in a big city, that there's a philosophical sense that you do what you can in small, remote parts of the country, and that you have to be, I guess, a certain readiness for the fact that you are going to have bad outcomes that in bigger centers may not have been, that may not have been as bad because you have access to tertiary care. So that was her. The second physician I talked to is an Inuvik family physician who has ESS training, so enhanced surgical skill training, who works at Inuvik with a small team of family doctors who support a very, very busy surgical practice up there. So they've got GPAs there, they've got GP surgeons, and as far as I know, they're doing surgery in probably one of the most remote and northern places, not just in Canada but in the world. They provide tonsillectomies there, they do C-sections, hernia repairs, lots of endoscopy, lap tubules, DNC, the whole works, and they're doing it more than 1,000 kilometers north of Yellowknife. And so I talked to this physician and asked him about what clinical courage means to him. And the first thing is that he described himself as somebody who, he grew up in a small community himself, so he was accustomed to the rural and remote dynamic just from living it as a kid. And he really felt that it was ingrained in his personality, that, really if the medical school had looked or asked in the first year of his training, they probably would have picked him out as being one of these guys that worked in this type of way in northern Canada. And so for this physician, clinical courage is demonstrated when when the practitioner is putting something of their self on the line, that there's risk to the patient, but there's also risk to the practitioner, maybe the practitioner's reputation, the practitioner's confidence, those sorts of things, and that the whole risk discussion is shared and between the practitioner and the patient, and that central to courage is understanding risk. And that this risk isn't just defined by us, it's also defined by the patient. And he told me this lovely story about trying to convince a patient to go to Yellowknife to have a C-section. And she had all sorts of risk factors for doing surgeries there. And at the end of the day, the patient said, to this physician, I understand the risk, I'm willing to take it, but I really, really need to be home closer to my family. And so that whole risk discussion became much more collaborational with the patient. The other thing too is that, it's kind of obvious in some ways to say, but is important, is that risk is also very context specific. And so the things that we do in rural and remote communities to best serve our patients and keep them closer to home, won't be the same kinds of things that would fly in North Vancouver or South Calgary. So these types of the types of things that Mark would do, the fact that this GP surgeon and Inuvik, obviously we're not doing that in North Vancouver and South Calgary. So the last family physician I talked to is a very, very very experienced family physician who's had lots of roles throughout Canada, both as a rural practitioner and with the college and with family medicine training programs, and asked her the same question. And for her, clinical courage is not necessarily being comfortable with your limit. We're not asking docs to be comfortable there, but it's more knowing when you're getting close to it and having a clear process how to manage that approach. It requires actually deep self-knowledge and a willingness to stretch and a comfort with your own vulnerability. It requires, and this kind of gets back to what the other physician was saying, is it requires patient interaction and actually patient consent. You need to have conversations with your patient about approaching the limit of your skill set. Clinicians should move to the margins of their skills in partnership with their patient and your healthcare team. And so a big point of what she was saying is that this is completely opposite of what I think all of us understand as the cowboy, right? And so a cowboy lacks self-knowledge. They lack humility or vulnerability. A lot of the things that they do is more for kind of ego and self-aggrandizement. And we all know that cowboys are really dangerous, right, in the medical world. This is a different kind of approach. This is approaching things with a certain amount of self-knowledge, caution, vulnerability, and patient consent. One of the things I found in the literature that really, really nicely summarizes, I think, a lot of themes that came out in my interviews was actually by Dr. John Wooten. And what he described is clinical courage is inhabiting the gray zone at the fringe of competence where the fog gets thicker as we approach the edge of the cliff. How far is it reasonable to go? How close to the edge must we go before we put down our heavy load? He goes further and says, clinical courage is that inner debate that we must all have with ourselves, in that space where the needs of our patients and the extent of our training and experience intersect. I think that's a lovely, lovely synopsis of this concept. The next part I want to move into, and it goes back a little bit to what my colleagues were telling me, is clinical courage teachable? A lot of what they told me in the interviews was it's a quality of an individual. So, the surgical skills, or the enhanced surgical skills colleague that's working doing GP surgery up in Inuvik, I mean, he said that this was kind of part of who he was, right? So to a certain extent, like, how do we teach this? And is it teachable? Certainly, when you look at the collaboration between the SRPC and the College of Family Physicians and their rural roadmap for action, they clearly indicate that clinical courage is teachable. And so in direction one, they say that one of the important things is they want to reinforce the social accountability of medical schools and residency programs to address the healthcare needs of rural Indigenous communities. So in action 4 there, they basically say that you need to provide really high quality rural clinical and educational experiences to students and to medicine residents to support experiential learning, enabling medical learners to feel comfortable with uncertainty and to gain clinical courage. So they are really highlighting clinical courage as a big part of rural practice. And so when I talk to my colleagues and ask them, is it teachable? There are a couple of things that they said. So not everyone is built for remote and rural work. Perhaps programs can try to select for it, or people self-select through CARMs, that kind of thing. Remote and rural work, I think we need to acknowledge, isn't for everybody. But clinical courage can be modeled by practitioners. So everyone has self-doubt, and it's okay to demonstrate that vulnerability. So when you're working with learners, be careful with the stories we tell. And sometimes we tell the really dramatic, rare story about some horrendous situation that can sometimes overblow the actual risks of providing remote and rural care. So yes, every one of us, I think, working in small places has situations that really pushed us to our limit. But the reality is that most of rural and remote care is actually just, routine family medicine stuff. And I think if we really focus on only the really bad things when we're telling stories, it can scare people away from rural and remote practice. And that there's this distinct difference between a practice that is limited by caution and one that is limited by courage. And so I think physicians, we often are worried about medical legal implications, and rightly so, about some of the things that we do, and we tend to be a bit cautious about some of the things we say. But it is important in small and remote places that it's a bit of a different dynamic, where you move from I would never do X to whatever that is, intraosseous IV or a lumbar puncture, whatever. But to an idea that I haven't done, whatever procedure or prescribed a medication or whatever, but am prepared to do it if needed. So from the college perspective, the interesting thing about the college is they take a bit of a different take on this. They really feel that from the College of Family Physicians of Canada that the clinical courage isn't a quality, it's a competence. And so a few years ago, the CFPC created a working group on the assessment of competence in rural and remote family medicine, in which they examined the competencies required for rural and remote family practice. So they convened a small group of experts, sought broad consultation. And interestingly, when you look through the priority topics, and those priority topics are on the internet, you can all have a look at it. What's fascinating about it is that, I can't remember, it's like number 18, it just jumps out at you. One of the competencies after pediatric trauma care and sepsis and all of these things is clinical courage. And so they're clearly outlining this as a competence. And these priority topics that they have are defined as the main problems or situations a competent practitioner should be able to resolve in a clinical domain. These are teachable, they're accessible, and make up one of the pillars of rural and remote competence. And clinical courage is one of them. And so this is actually what it says. And so I'm just going to read this off. So topic 16, so clinical courage. So this is how you take clinical courage from a quality to an accessible competence, according to the college. And so basically what you do is you're in a clinical situation that might surpass your level of comfort. The things that you want to do is don't minimize the situation. So, don't underestimate that how the dangers of where you are, but at the same time, don't overreact. Take a deep breath. Assess comprehensively. Consider your resources, what's happening, what the weather is, if you can get a medevac in or not, what the patient dynamics are, and then develop a management plan. So all the things that we usually do. Step back and think about what you're doing. Take a minute. And then when you're considering an intervention that surpasses your level of comfort, be prepared to take a risk by drawing on parallel education or knowledge, anticipating difficulties, and consulting when appropriate, and seeking local and external support. That's sort of an interesting one because your local supports may be might be an RCMP officer, right, who may be able to help you restrain a violent patient. It may be your fire department who might be able to help you, with some airway issues or those sorts of things. So you those sorts of external supports you'll have to get quite creative with. And then, you follow a patient-centered approach, and this is what was talked about with some of the docs I interviewed, and that you maintain communication with your patient or advocate in order to ensure that you are acting in their best interest. And then after it's done, is to take your team and debrief. And the importance of debriefing isn't just obviously with clinical courage. Debrief is a really big part of acute care. But a debrief in this situation is really important, and then identify learning opportunities out of that debrief. And then when caring with a patient with an uncertain diagnosis in a rural, remote area where resources may be limited, recognize that repeated assessment over time will provide reassurance that appropriate care is being provided. Number 4, I can't tell you, and I'm sure many who are listening to this right now, that probably one of the most important tests I think all of us have in rural and remote settings is the test of time. We know our communities. Often access to us is not quite as difficult as it is in bigger places. And the test of time is probably one of the most important tools that we have. And I really appreciate the college highlighting that. The college's take on this is that it is in fact a competence, and that it is accessible, and it is in that whole series of steps that I went through is teachable. So what system supports do we need to have to support clinical courage? And this is goes beyond teaching, but more about, if when you look in your neighborhood, in your community, just identify what some of those things might be out there that might support you in moving to the edge of your competence. So the Rural Roadmap says that across the country, we need to implement standard policies within health service delivery areas that require acceptance, timely transfer, and appropriate consultations between rural medical facilities and secondary hospitals supported by regional training and patient care networks, including generalists and specialists. And so what does that mean in the Northwest Territories? Well, in the Northwest Territories, we have basically now, we're moving to a system of medevacs that is virtually a no refusal policy. So if a practitioner or a nurse is calling from the community and is telling you that they need to medevac somebody, at the end of the day, it's their call. It's not the call of the accepting facility. So this is an important way that we support our colleagues in small places, and I certainly challenge other jurisdictions to adopt the same type of policy. This is a picture actually of of a real transfer happening in looks like the Kitikmeot most likely. In Nunavut onto one of the King Airs that air ambulances that transfer people in, and so this is the beginning of a very, very lengthy process of transfer. And so when patients call for medevacs in the Northwest Territories or Nunavut, the time between the call and them actually arriving at secondary care is in many cases many hours, sometimes as many as 8 hours. So things change, weather changes, those sorts of things. And so if someone's calling for help, we send it as soon as we can. Other system supports, and we're starting to see an explosion of this type of thing all across the country. But so you partner with rural communities and rural health professionals to develop strategies to guide implementing system-wide coordinated distance technology to enhance and expand local capacity and improve access and quality of healthcare in rural communities. So for us, that has basically been a call to the expansion of virtual care. And I think across the country now and across the world, we have all sorts of tools that can enhance virtual care. And now the challenge, I think, is actually creating a new physician in many health systems that what they do is virtual care. And so they are available to support over long periods of time the acute care needs of small places. And in the Northwest Territories, we're working on a system, hopefully, that will address some of those things in a proposal that's working its way through the system right now called the Territorial Acute Physician. So hopefully that will come to pass, and we'll have a virtual care doc in the Northwest Territories in short order. So that's really the end of my talk. I think some things to take away from this you may want to discuss or think about are, do you actually buy that clinical courage is a competence that can be taught? Or is it a quality that med schools could identify in potential students, or is it some sort of combination? And then if it can be taught, how do we teach it? I've talked about a few different ways, the approach of the college, and then, system-wide, how do we better support practitioners who are working at the edge of their skill set and making sure that our systems are set up to support that. So that's the end of my presentation, and thank you very much for listening to me today.